all right, this is what it looks like. This is follow-up. And this is what I think is quite impressive. Look at how many black holes you have in the tumor. So a lot of those tumors have died, and you highlighted favorable tumor biology, right? One of the things to note here is that there still is some viable tumor in that right hepatic artery, or that right hepatic lobe tumor. And that's because that tumor was drinking like nobody's business. And so the bottom part of it drank, but the top part didn't. Here we go. So the top part was the furthest away from perfuse. So now you're here. What do you do next?
So first question is, what size vial did you pick for that right side?
For that right side, it was 27. It was two combined vials, so it was 27 GBQ.
Plus a 20 plus a 7.
And so I did, and it was because
First
I was
week or second week?
It was second week. So if I dose 120 or greater, or 120 to the 200 range, I'm a week 2 Monday, Tuesday person. My rad segs though, majority of them are 500 or greater, and I'm a week 1 person. So I dose week 1 vials for for high dose rad segs, and it's a similar sphere concentration if you think about it, because it's 3 days later. So if you dose in that 250 to 120 range, week 2 Monday, Tuesday tends to be the day that I choose, and it was a 27 GBQ vial, or 27 GBQ worth of activity.
Any new disease on this?
No. So everything, black holes, and then no new disease.
So if there's interest in, trying to get, well, two things. Number one, 1 month is early.
Yes.
Right? So one option is just to wait it out, right? Like his biology is not exploding with tumors. Just wait it out another 2-3 months, because especially larger tumors, you're not going to often see I would say the majority of time, you're not going to see a complete response at 1 month for an infiltrative 7-8 centimeter tumor. So that's one option. Your second option is to retreat. I personally would probably just wait it out since its biology has been stable. But let's say you wanted to retreat it, maybe just retreat that right hepatic tumor and just up your particle load.
Yeah.
Right? So whatever you use, you can use the same dose. Just double the number of particles, however you want to do the math, whether you want to use glass, you can you switch to resin and increase your particle load that way. So you can get more spatial coverage, because as you said, the bottom part was drinking all the particles.
I might remap the right side.
Okay.
Just to see, and we're not seeing every second, everything you did during the case, but I tend to do a surrogate 0.5/5 injection where I'm treating from, and sometimes when I do a cone beam with that, I can see, the tumor is mostly drinking it in the inferior part. So maybe I should select another vessel. So I would remap this and kind of try to figure out, is there some vessels I can get into to treat this versus, do I need to increase my particle load? And then I'll go to Zach in terms of how he would have treated this maybe with resin. But yeah, I would remap, and there you see you're pretty much selecting the vessel that probably would take you to the rest of the viable tumor.
I think our goal here is also super important, right? Like, so we have a trial, the rapid trial done out of MD Anderson, that showed that even at 3 months, the complete response rate was relatively low, but having done nothing between 3 and 6 months, at 6 months, the complete response rate goes higher. And they were larger tumors in that study. So waiting, even if you have viable disease, quote unquote, might be the right thing to do, right? Because you still continue to get response. And then the second question, we have is, what is our goal, right? If our goal is to somehow downstage this guy to transplant, makes sense. Go in there, you got to get this thing non-enhancing, because that's what's going to get you on the list, right? Successfully downstage to be listed. However, if this guy's, ultimate goal is just disease control, I think you wait a little bit longer instead of just like rushing and doing therapy because we're treating an image, where he might, or she might be better off just like waiting to see what our final result is at 3-6 months before making a determination whether to go back in. I think what you didn't show, which would have been really helpful for this tumor, was a SPECT afterwards, or a PET.
Sure.
Because if you had complete coverage of the tumor and you still had some viability, okay, wait it out, right?
Exactly.
Right.
But if you got a SPECT and it only had it
only at the bottom
by the
part.
bottom,
Right.
Yeah.
much easier decision to come back in.
and
So
treat.
I was assuming that
Yeah,
that's what the spec looked like, but
And
that's a great point.
I will tell you, there was definite heterogeneity in that tumor, where it was, if you look back at the bottom, you knew that it was kind of all saturated down there, and it got some radiation got up there, obviously, but not as much. And you can see on that image on the left, right, the top part of the tumor is what's showing parenchymal enhancement, and the bottom part's not. And that's kind of what we saw in the SPECT. And so my thought process was, everything's holding steady. Let's go back and remap and try to get past the feeders that were drinking everything, and then go up And that's what we did here.
But to cover a very important point, and I think this is going to become more important as we go, future in the future of dosimetry. You could have a high average tumor dose with this picture, right?
Mm-hmm.
You could have treated the bottom half and got 1,000 gray to it, but the median tumor dose might be 1,000 gray, but the coldest part of it, the top part of it, maybe only saw 20 gray, 30 gray or something like that, right? So as we start to figure out how we want to dose these, maybe looking at the entire tumor, particularly with these larger ones, to see what the dose to the coldest portion of the tumor is going to become a lot more important.